Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast.
Hi, everyone. Dr. Eric Westman here, and welcome to my channel where I get to review and typically debunk nutritional misinformation that's online. But occasionally I get to interview the movers and the shakers in the low-carb or nutritional world. And it's my great pleasure to introduce Dr. Shebani Sethi, who is a psychiatrist of all backgrounds. And normally I talk about obesity and diabetes reversal, metabolic illness that occurs, below the neck. But perhaps the same issues go on in the brain, which, of course, a little internal medicine humor, that's my background. The brain's just another internal organ, right? And so we artificially have a separation between, the body is totally connected, I know. So, well, welcome, and please tell a little about yourself for someone who is brand new to who you are and the work that you do. Thanks so much for being with me.
Yeah, thank you for having me here today, and pleasure to be here. And I am a psychiatrist, board certified in psychiatry as well as obesity medicine. That's partly probably because of inspiration from you and the work that you've done over the years. And I run a metabolic psychiatry program at Stanford. I'm an associate professor, and I see patients, but I also run clinical trials.
So how you spent some time at Duke, I recall, some pre-pandemic, some years ago. But even before that, how did you get involved in medicine and psychiatry, and then ultimately the work that you're doing now? What was that pathway?
Yeah, so that you mentioned Duke, it brings back a lot of memories, a lot of great memories, and a lot of my early years in both medical school and training, while I had, the pleasure of working with you, I saw a lot of this, obesity obviously was an issue, weight gain, mental health was also an issue. And I saw oftentimes that, we silo ourselves a lot in different fields with mental health and with internal medicine. And so it ultimately, I guess, dawned on me when I was working with you and others that there is this relationship and we shouldn't ignore it. One of the, I think that one of the deans at the medical school at Stanford had said to graduating medical students several years ago was the greatest discoveries occur in the intersection between fields. And I completely agree with him because this is something that I think can be often overlooked. And especially there's a gap in care that, folks aren't necessarily having their mental health addressed or their weight addressed or their metabolic dysfunction addressed while they're seeing a psychiatrist or vice versa. So it ends up being something that I think was helpful to at least hone in on during the early years. And I think working with you also was very inspirational because I saw that you made strides to make efforts and to actually put those things together. You had a patient that had schizophrenia and treatment-resistant schizophrenia, if I remember.
Yes.
And I saw improvements in that patient with the hallucinations. At first, I was very skeptical, like, was this actually something that was helping the patient for psychiatric symptoms? Of course, the weight, I wasn't skeptical about the weight loss or the insulin resistance, but over interviewing the family or the caregivers of that particular patient and seeing all of the medications that this patient was on over the years, and then seeing other patients that I have seen over the years as well, it's very rewarding to see what an intervention can do, like a dietary intervention for improving mental health outcomes. And that's really, I think, what got me very interested in understanding nutrition better and realizing that I needed extra training in the obesity medicine aspect in order to get kind of deeper into how I can apply that for those with serious mental illness. And I think that's really where it started for me. And I went into a psychiatry residency training program knowing that I wanted to focus on metabolism and obesity as well, and eating disorders. So I kind of carved out this path in residency, and created it in our program and offer it to residents now. And now I get to train other residents and see patients and be able to integrate these two fields that I think should have been integrated a long time ago. So.
For sure. So to kind of recap, you went to clinical trial training or had it along the way and started doing research studies, which in contrast to other psychiatrists who are into this area, they're writing books and being very clinical. I really am reminded of the work we did 25 years ago now that was starting to assemble the metabolic changes for obesity and diabetes. But it was different because I knew that people could lose weight on a low carb diet. Because we knew that, we just didn't know it was safe. So now let me, give you the baton to just say, after 20 years, we know it's safe. So now you're exploring how does it work for mental illness, so how do you see what you're doing and where you're starting in this kind of big field? I mean, schizophrenia, I don't know how many people like Doris will be improved like that, but even if there's a fraction of folks, it's just a devastating disorder that, current medicines don't. Well, I might even start with, do medicines really help a lot of the mental illness that you deal with, or is it just kind of like a Band-Aid, like the metabolic, treating diabetes or managing it with medicine really doesn't fix it, So,
Yeah, these are great questions. So first, I just want to say, wow, 25 years ago, you're right. It was. So much time has flown by. And, one of the things that really struck me was when you saw your patients, you treated them like family. And that's very rare. And, there are books, I think, that you took out and you showed, and it is kind of rare to see physicians like that this day and age. And so part of that, I know I'm going a little bit on a tangent here, but I do want to point this out because I think it's very rare and it's special. And I think that really did inspire me to go into the clinical side in the way that I did. But at the same time, you were also doing research. And so Duke has this program of physician scientist type. And I didn't go into the Duke program thinking necessarily that I was going to be a physician scientist. I didn't necessarily have plans to go into research. But I did research. I started off with HIV, drug resistance research in medical school, which gave me a good, robust training in clinical trials and in research in general. In residency, I had gone into actually a drug trial where I was looking at an obesity drug, Kisimia, in binge eating disorder and bulimia. So it was a eating disorder focused RCT study. And that by itself, metabolic psychiatry really came about as this is a metabolic intervention actually improving mental health conditions? Is it improving psychiatric outcomes? And in this trial itself, there's an obesity drug, what we call metabolic medication, right? Is actually improving a psychiatric outcome by itself, like binge eating or purging itself. The weight also, of course, is also improved, but at the same time, it's the eating disorders are improving as well, the symptoms. And so that was also another kind of confirmation to me of, well, we're heading in the right direction. There are different factors, probably different tools that can be used, metabolic interventions that can be used to improve psychiatric outcomes. And a lot has been studied now on that, and more is being studied. But with the ketogenic diet specifically, I realized the more patients I was treating, I couldn't just be this one physician treating a patient and then have a clinic and that to me felt like, no, I need to make sure other people are aware of this. I need to make sure that it's written in the literature, or that's kind of why I went into the research piece more. And so I did this pilot trial with the ketogenic diet in schizophrenia and bipolar disorder as well, and looked at the metabolic outcomes and psychiatric outcomes, and adapted a lot of your protocol with others, and my experience with folks at SMI. And so that was what led me into doing it, to answer your question regarding that. And I think the other question you had mentioned is about the drugs itself and how effective they are in this population. So the objective of this study was to really do a proof of concept study, look at, well, are the metabolic outcomes improving? Because we know that a low carbohydrate or ketogenic diet is helpful in obesity, helpful in insulin resistance, right? But is it helpful in those people that have serious mental illness that also have medications on board that make it harder for them to lose weight, right? So that's one question.
Many of these psychiatric medicines cause weight gain, right? So that's I'll see, take the history. I was depressed, was put on a medicine. I didn't really know what was going on. And now they're 100 pounds heavier. I often kind of shake my fist at the psychiatrists who aren't paying attention to the weight, but I guess you're saving the life, of the depression, and you might not focus on that 100-pound weight gain. But anyway, so
Right.
treating a side effect, and then seeing if the psychiatric disorder gets better would be giving insight into. You're not directly saying it's going to fix the psychiatric problem, but at least it can mitigate the weight gain of the medications that are used. That's great.
Right. So that was one of the questions. Is it going to actually help with that side effect that is a problem? And the side effect could be weight gain, like you mentioned, or it could be dyslipidemia, or it could be high blood sugar, insulin resistance that can come about. And they can be normal weight and just have insulin resistance. So it was kind of a question of, well, is this intervention going to help even these patients that are on these medications, one, and then two, does it help their psychiatric symptoms? So what's the signal, right, that we're getting? And ended up being very encouraging. And we can go into that later, but I think the idea behind the study was that. And sometimes I get the question of why not just have everyone be enrolled, and why not instead of someone with metabolic dysfunction. And I did that on purpose because I wanted to really ask that first question that we talked about.
Yeah.
Like, is this actually going to help people that maybe discontinue their medications because the side effects are not something they want, right? And oftentimes they're monitored across the whole. They're monitored by psychiatrists. Their A1C is monitored, their weight's monitored, but it's not treated. And there's this idea, I think, amongst my professional community that they go to a specialist to, get that addressed, or a PCP to get that addressed. I think we need to take a little bit more, as a community, more responsibility for those pieces. And the effectiveness of the medications for serious mental illness are variable. They can be life-saving, but they're variable based on the patient. And mental health conditions are not homogeneous. They're very heterogeneous. And so it becomes quite difficult it's a difficult to treat condition.
Well, I would like to first start with what your latest thoughts are about binge eating disorder. And I was trained as an internist, got very little nutrition training. When I finally got into the weight loss world and studied the Atkins diet, which was taboo, nobody really had studied it. Then I started learning that in the dietitian world and then the psychiatric binge eating world, limiting a food group, like cutting out carbs, that was taboo. But it was like, you can't do that. This goes against everything, So now I'd like to tell you just a brief story about someone who saw me. She was admitted to the psychiatric ward at a local prominent university hospital, and they wanted to put her on medicine for it was actually anorexia. And she was down to about 88 pounds, and she should be 140. And when she was there, just to see the confusion here, in a book she wrote afterwards, she said, I tried to tell them that it was my stomach that was the problem, not my brain. And yet they wanted to give me medicine for my brain. And she said, I'm not in the right place. So what really wasn't a psychiatric issue of like a primary here. It was from the gut. And it turns out by cutting out the food she was intolerant to, she figured out that she had a problem. It included, highly processed foods, but also some vegetables that people normally can have. And it was probably gluten involved and all this. So she did a very strong elimination diet after I had met her and said, I don't know what to do. And she kind of fixed herself finally by figuring out what foods were causing the problem. And I have to say that the radical nature of cutting out junk foods as a treatment for binge eating is not radical to me anymore. So when someone says that you can't cut out, well, it's a different paradigm. What we're looking at is that these are foods that you can't control, and of course you'll binge on them. So why don't we stop those foods? But that for years was thought to be, in fact, probably in your circle, in your sphere, that you're looked at as doing something bizarre when, because the tradition is that you want people with binge eating disorder to eat on a wide array of foods. So what do you know about, explain what binge eating disorder is, and then what your research has shown light on.
Yeah, so the eating disorder world is a kind of area that I had a lot of interest in early on and worked in quite extensively. And so what I'd say is with binge eating, it's characterized as a disorder where you're consuming a large quantity of food that's associated with basically a loss of control. The patient endorses loss of control. Now, there are folks that can binge eat that don't endorse loss of control that's associated with the binge eating. So there's a distinction between what the field calls binge eating disorder versus just binge eating, some subjective binge eating. And you also have to have certain symptoms in addition to that, which kind of match the criteria, like either eating alone or in shame, feeling guilty afterwards, eating more than you intended, but also when you're not hungry and you're still eating. And it's more of a maladaptive pattern behavior that ends up happening. And so that's kind of how it's been characterized. With anorexia, we think of it as a neurocognitive condition as well. And, it's interesting the story that you mentioned, because oftentimes with anorexia, they do endorse problems in the stomach. And I think it's really important to have a shift in paradigm of looking at metabolic pieces in the evaluation of psychiatric care. Now, eating disorder world has been primarily psychology, some psychiatry has been in there. And so, yes, I am probably a little bit outside of the box in this area, because I do look at, medications for eating disorders or obesity drugs, right? Or, I do look at changing the diet as part of the eating disorder, because a lot, and I'll tell you the reason why. There has been a lot of literature that there's a dietary restraint hypothesis that if you don't, if you restrict yourself in some way in one area, then you're exacerbating your eating disorder symptoms. But that's primarily been based on research that is done with low-fat diets. Or, it's not been in, say, a low-carbohydrate or less ultra-processed food environment. So by not looking at the other side of the coin, by not looking at, well, this is not normal diet to begin with that we're eating, right, as a standard American diet. And what is the standard American diet doing to our cognition? Now, we know it affects default mode network in our brain. We know it affects reward pathway. We know it affects cognition. And so if cognition is changing and the structure and function of the brain is changing with food, and if we're not eating well and it leads to increased inflammation or more insulin resistance, then we're then creating psychiatric symptoms. We don't know exactly what the mechanisms are, but that's my take on this. And I think that we could get into the whole health at every size movement, and we can get into that side of things. But I think that there's a good intentions that ultimately the community has. But I think what's being ignored is the metabolic dysfunction that is there in the brain, centrally and peripherally, in these conditions. And I think that's where the field really needs to be moving forward towards. And so that's why, as part of the case series that we wrote, together in conjunction with other eating disorder experts, we were in agreement that this method, low carbohydrate ketogenic approach, has actually been helpful for binge eating symptoms. And, we theorize that it's dampening the reward pathway, the dopamine response. It's decreasing ghrelin and hunger, right? So there are a lot of those physiological changes, and you're also stabilizing glucose. You don't have these peaks and troughs of the glucose where you're affecting the insulin release as well. And so the idea is that, well, once you're kind of you're stable, you're not necessarily feeling as like you have those cravings. So it's physiological, but also I think cognitively changing.
I used to be in the nicotine world, the smoking cessation world. So for about 10 years, I worked on clinical trials using medication, mainly nicotine replacement, the drugs that led toward Chantix and all these other ones.
Yeah.
So that I think I was primed for kind of thinking of food as an addictive substance. And then, of course, the whistleblowers come out saying the food industry is making food that you can't stop eating. And, you don't see Lay's potato chip, but you can't eat just one anymore. I think they would get in trouble with that kind of advertising now. But the idea that food can be addictive and that with binge eating, that abstinence might be a cure for it, to me seems pretty natural. But to the world around us, the treatment world, it still seems kind of bizarre, kind of like for dietary obesity or diabetes reversal. It's so obvious to me that you would want to cut carbs, because diabetes is a problem of too much sugar. But so we do buck these paradigms. But I really admire your approach, which is let's get some real science. Let's get some studies going, because that's really what's needed for replication and for persuading the medical community, which thinks it's based on science, maybe not all the time, but so are you doing any work now with binge eating, or what are you? You can repeat there.
Well, yeah, I would add that the evidence for that hypothesis was not very robust with the dietary restraint hypothesis, and it was very focused on one type of way of eating and looking at it like low calorie and low fat, and that's not how everyone necessarily should be eating, right? So is regarding to the ultra-processed food, and yeah, it's really interesting that you mentioned the nicotine. I remember that you had background in that, and you had worked quite extensively in that area, and I recall that, and I think that the idea of abstinence is a great one. It works, and research shows that, and so why shouldn't we think about ultra-processed foods that way is a question, but at least harm reduction could be taken as an approach. I'm hopeful, actually, hopefully, with Robert Kennedy's at least opinion on ultra-processed food and wanting that away from schools. I think will be a huge improvement for the food supply. Even if you think about big tobacco and big food, I mean, this is not that different. So that would be lovely. I have a 5-year-old son in kindergarten, and I don't want him to come home with pirate booty every day, you know, like I'm trying. So I agree. I think that would be.
Well, have you explored that area? You're like me, you're an adult practitioner, right? I mean, or can you do research with children in schools, and is that on your radar?
Unfortunately, no. I'm not a child psychiatrist, and so I treat adults, and I do with eating disorders. I will treat those, you know, at least in some teenage spectrum.
Yeah.
But with binge eating, to the question you had about binge eating and how that might be related to the work I'm currently doing. Well, we've designed a randomized control trial that we're waiting for IRB approval at this point at Stanford, which is looking at ketogenic diet in schizophrenia, bipolar, and major depressive disorder. So it's transdiagnostic and kind of the next step from the pilot study that we did. And this would be an adequately powered trial. Now, a lot of the secondary outcomes that we're looking at, the primary outcome is quality of life, but a lot of the secondary outcomes will include binge eating, for example. I'm going to do a sub-analysis looking at that, but I'm not necessarily doing a trial specifically only in binge eating disorder. I'm kind of focusing on the main SMI population right now, just to kind of get the kind of more, I guess, more prevalent conditions first with the metabolic issues, especially, or rates are so high.
So when you're designing a study like this, you could take the worst of the worst who nobody else wants to treat. In fact, that's kind of what my clinic has turned out to be, where other doctors don't, you know, they're on 12 medicines and they don't really care what I teach about because they're over there, they really can't handle it. But then that's putting a strain on a diet. It's now thinking about mental illness. If it helps a percentage of folks, or let's say it's just a mild treatment and you start with the sickest of the sickest, you might not get, while the IRB might say, okay, sure, you know, no one else can help these people, you might not give the diet a fair shake. So I'd be curious, are you targeting folks, trying to get people who are not being able to be managed on medicines or early on? Or it'd be ideal if you took new diagnosis, you know, incident mental illness, and then randomize folks to either diet or treatment. But I don't suppose an IRB is going to be ready for that yet.
Yeah, that's a really interesting question. And, you know, a lot of the folks that come to you, you're the hopeful doctor. You know, they're your
Clinic of
give
last.
them hope, right? I think with the IRB, I'm not sure if it would be an issue or not, but it's a good question because you end up then studying a different population where it's, you know, first diagnosis, you know, first episode psychosis type of diagnosis versus someone that's treatment resistant for, you know, 10, 15 years. And they are different populations, but I am trying to see, you know, I'm trying not to limit the population too much, because we do need to recruit for an adequately powered study. It's 120 folks, and they can have any of the 3 diagnoses. And even with treatment resistant cases, I am hopeful about some improvements. I've, you know, recently, so a study that I've been involved in at UCSF, which is also an RCT for patients with a ketogenic diet in schizophrenia specifically. One of the most treatment resistant cases I've seen, I think, so far. I entered that study and I still saw some improvement. And so it's maybe not all these assessments can detect all of the improvements because they are designed the way they're designed. Yeah. And so we may detect all of it, but it's, yeah.
You know, often I look at the drug company studies. I was reviewing a few today, and you know, 5,000 people recruited all over the world with dozens of centers, and you know, like Really, but when you're targeting starting with small group, the other thing I was thinking about it is the story of Matt Bazuki. So let's say you have a family that's super supportive. So I wonder in your RCT, if you come in, whether someone can follow the diet is really a major factor of whether you're going to see benefit from the diet.
Absolutely.
If you give everyone a drug, but no, they cheek the pill and they spit it out, you really don't assess the drug. It's whether someone is going to follow and do it. So I wonder, so it seems to me you want people with social support or at least an ability to have the assistance to follow a program, or ideally it would be a feeding study like Jeff Volek has done somehow at Ohio State and at UConn. He would get the food or maybe through one of these, a lot of people use now these food to home types of programs.
Delivery services. Yeah. So we have been doing that with the UCSF study, food delivery, and patients like the meals. They're pretty happy overall. With the pilot study, we didn't do that. We taught them, and we provided them with books and recipes and health coaching. So they received support, and surprisingly, actually, the adherence was actually pretty high, 90% or more. And this was a mixed population. And it wasn't a mildly ill population at all. I think the average suicide attempt, a baseline, was about 1 or 2 for this population. So I would say that the way that it's structured is really important, making sure they know that. So we had weekly appointments with them, making sure their family was on board, or a caregiver or their partner, coming to a support group, or making sure the family understood or knew what to do to help them. We would measure them, their ketone levels, and are planning to do the same thing for the RCT to make sure that there is support around. And I think that matters a lot with this population in particular. And having that, I think feeding study would definitely be, inpatient. It would be a lot, it'd be more expensive, and it would be hard to recruit. But I'm hopeful that we'll be able to do that in an outpatient basis.
If there's interest, it's not all that expensive. We did a pilot study using the Duke student-run program that fed people once a week, and I got to change the food delivery for some people. We gave them meat and veg, not fruit. And one person, we just delivered it once a week, and she reversed her diabetes, came off 600 units of insulin with just the weekly contact. And so there are a lot of ways to, if you're finding there's trouble with adherence, really important to say that, that didn't really test the ketosis part of it. But now I'm wondering, what's your take on, has there been any research on drinking ketones or the keto gummies or those sorts of things with mental health? Have you seen anything in that regard?
Yeah, it's pretty new still, looking at exogenous ketones in mental health specifically. I haven't researched exogenous ketones myself. I have used it in clinical practice occasionally, especially in times where they know that they tend to have, let's say, mania in the spring, in March, and maybe in addition to their medication, we want to just kind of top off a little bit. It does help with some prodromal symptoms, I have found, and that's been helpful for a lot of my patients. But as far as the research is, I'm not as familiar with that for mental health specifically, and I don't think it's going to be the solution. I think the kind of endogenous approach of doing a ketogenic diet is going to be so different.
Well, as you know, I kind of relaxed my criticism in that, it's not like the keto diet has penetrated pop culture to the extent that so these other things could be adjuncts, of course.
Yeah.
And, but interesting in the internal medicine world, there's a drug that causes ketosis. It's the SGLT2 inhibitor. It's used for diabetes and heart failure. And they figured out that the mechanism of heart failure reversal is probably the ketosis. And so now there are studies being done of exogenous ketones and even IV ketone to look at heart function and looking at it in a very detailed way. And yet the investigators don't know anything about a keto diet. So it's coming around, they're kind of learning, ketones are good for heart failure, but how do we get ketones?
Right.
Anyway, so we might actually be seeing the medication that are being used, the GIP and GLP1s, because they're so strong. So many patients that I see other doctors using these medicines, they must be in ketosis. I mean, the weight loss is just really dramatic, and I wonder if there will be any reports of mental health improvements with the second generation ones. That's the Zepbound and Mounjaro.
Yeah.
This seems to be so appetite suppressing. If you don't have a GI side effect from it, I think it's going to help a lot of people. And then, of course, they need to realize that it's the diet when they're done with the drug, or they're just going to get back to the.
Yeah, that's really interesting. I know that there are some trials looking at GLP-1s in like alcohol use disorder. There was stuff with binge eating disorder as well, and they have pretty good outcomes. I believe there is one that's starting for OCD, as far as I know, but as far as whether it's kind of the semaglutide or whether it's Mounjaro is tirzepatide, it is I don't think it's the newer one. It's the semaglutide most likely.
And so the first generation, and then there's the second, and then there's going to be third. It's fascinating to see that develop. In fact, I sat in a board meeting of the Obesity Medicine Association where the Novo Nordisk team came and said, here's our plan for the next 10 years of developing these drugs. And it happened. It was pretty amazing to see that progress. So kind of so we have the internet, we have these stories of dramatic improvement. We, the Matt Bazuki reversing his disease, and the parents happen now to be philanthropic and funding a lot of research in mental health. What's your take on, so these are individuals in cases, is this going to be a big deal in terms of metabolic psychiatry and fixing, should we, I try not to be too sensational about things, but The Magic Pill, the movie, basically showed this unbelievable transformation of a child behaviorally, where they just took the child off sugar and everything got better. I mean, is this the tip of the iceberg, or is this not going to be a big deal? It's hard for me to gauge using my internet sheath.
Yeah, I hear you. And I also, I'm the same in the sense that I don't like to sensationalize things as well. And actually, Bazuki family supported the pilot trial at Stanford. So very grateful to them for that. And they've generously funded many other researchers now doing trials that are focused in this area as well, with different conditions and with ketogenic diet specifically. So that'll be really exciting to see the results in the future for that. And also digging into mechanistic, aspects of the study too, with MR spectroscopy as well as fMRI and, brain metabolism, looking at default mode networks and changes. So I'm excited to see what the field will show. But as far as the case, kind of case reports that you're hearing here and there, is from our pilot, I'll say that across the board, I mean, even if you look at the people who weren't completely adherent and they were semi-adherent, but they're still 60 to 80% of the time in nutritional ketosis, they still had a benefit. And when you look at kind of the overall CGI improvement, it's clinical global impression, it's like our standard scale that we could use both in schizophrenia and bipolar. And it was 79% of them had at least a 1-point change. And that is, in our world, clinically meaningful.
What's the range on the CGI? What is it, like a 0 to 10?
It's like a 1 to 6 kind of range.
Oh, 1 to 6. Oh, so that's
Yeah, so a
big deal.
1-point change is a big deal
Yeah.
in that world. And what we did was, we made sure that it was 2 different physicians, and then we took the average scores to reduce bias as well. So a lot of I didn't necessarily measure cognition in, the kind of validated cognitive skills in the pilot, but in the RCT, I do plan to do that. And in other trials right now, we are seeing changes in the cognition aspects of these individuals. And I just saw a patient today who didn't necessarily notice a change for himself, but has been on a leave of absence from UC Berkeley for 5 years, has a diagnosis of schizophrenia. Mother notices changes in conversation and speech in a lot of different aspects. And that is a very common thing I hear in a lot of the patients. And so I am hopeful that this will help a significant portion of the population, but we can't say it helps everybody because that's not true. But it is helping a lot of people. And I think it's just one additional tool in the toolbox of a metabolic intervention that can be helpful. And to give someone, especially with SMI, another tool, in addition to the medications and the therapy they may be having, it feels empowering for them. They feel like they're in control, that they can do something about their illness. And you do see changes, and then it becomes rewarding and meaningful to see that. So
The acronym you use, SMI, serious mental illness.
mental illness, yeah. Sorry, I get acronyms a lot.
Meaning schizophrenia, bipolar. I mean, people who can't hold a job sometimes, right? They're pretty serious.
Yes, yeah. So schizophrenia, bipolar, and major depressive disorder is considered serious mental illness. And with schizophrenia, for example, 33% of them end up in remission. Right. So there's a lot that's not in remission, and will end up going to the ER, getting hospitalized. It's a cycle. And so the quality of life is challenging. They may not be able to hold a job, or they may have problems with, or they may be on disability. This patient in particular is actually going back to school. He's going back to UC Berkeley this year, and he started a ketogenic diet 2 months ago. But he's not necessarily seeing an improvement. But it's really interesting. After 5 years, he started a ketogenic diet, and then now wants to go back to school, and family is noticing cognitive improvements. So this is just an example from today, but I do have a lot of stories on my weekly basis that I see, and it's heading in a hopeful direction to me.
Yeah, good. And I'm just so happy that you're doing the hard work of writing clinical trials, going through that. Most people don't appreciate that. With today's world,
Thank you for saying that.
Some influencer, and it is a lot of work, and yet really important to do for us to know what proportion of people will get benefit. Maybe there are subgroups of folks who will be totally fixed. So that can't be determined by just looking at internet stories.
No,
I'm afraid.
it won't move the needle in our field at all with clinicians, and you know that, right? You need the science, you need the publications, you need the randomized controlled trials to actually convince our community to even think of it as a treatment.
Well, after some time, I'm not so convinced I need to change the needle of the pharma world of internal medicine. I've kind of given up.
Yeah.
I mean, there are, so you don't need, if anyone gives you grief about it causing harm, you let me know.
I'll let you know. I'll call you.
Send them Professor Noak's edited textbook that we all contributed chapters to. So especially when there's a big or reasonable risk of benefit here, there's really no harm. And that for so many, we got such grief for that
I think
20 years ago.
Yeah, I think the problem sometimes is when people are not educated on the topic, they have fear around it, right? And I think you might have taught me that actually. And I think I saw yesterday on Epoch Times dangers of ketogenic diet. I didn't even read it yet, but it's unfortunate because there's
and our patients, people read that, and many of them respond to that. So anyway, what a great chance. Thank you so much for letting me catch up with what you're doing and sharing your work with the rest of the world. The world has changed. I'm at a meeting, the SMHP, Society of Metabolic Health Practitioners, and one of the fellows who's in Dave Feldman's lean mass hyperresponder coronary artery angiogram studies at the microphone, and he's telling his result at a year, and I'm like, you're not supposed to tell us that. You're a study, and you're supposed to, and he says, I don't care, but he said he did not have progression of any atherosclerosis over a year in that study, and yet we're still waiting on a publication there for probable kind of, stalling to have people be able to respond. And so I hope time has passed, and I hope you don't have to experience any of that. And I guess I wonder, have you connected with the other the Stanford nutrition group? I have kept up with Christopher Gardner and that group a little bit. I wonder if there are any cross fertilization.
Yeah, no, it's interesting you asked that because so after the pilot study was published this year, Stanford, which by the way, I was really happy to hear from Stanford, it was like the most watched video of 2024, as we're reflecting on the year, and Stanford chose it as one of the top 10 scientific advancements of the year. And I was very humbled by that and excited because, here I did this pilot study and I didn't really, even though it was really meaningful for my patients, I didn't think that it would end up in Stanford's top 10, right? But I think, so Christopher Gardner had messaged me after the pilot study was published and was like, oh, hey, wanted to know if you'd want to collaborate on a study and this and that. Kind of, he had some concerns about ketogenic diet with, heart disease. And so we chatted a little bit. We didn't end up collaborating together, but that was the last of the conversation. I did speak with Mike Snyder, and we're going to be working together on a deep omics profiling in this RCT itself. So looking at proteomic, metabolomic data, epigenetic data in this study. So, maybe not Christopher Gardner's group, but we'll be collaborating with the genetics group and some other folks. There's actually another researcher who does research in ketogenic diets at Stanford, who's in animal models. And so he's looking at kind of the precursor to ketones and how that might be important. And so I think there's a lot of excitement outside of especially in the neurology world, epilepsy world. There's someone else that reached out to me from Stanford. So I think there's, definitely some community being built here, and I'm excited about that. We pre-printed a definitional metabolic psychiatry paper just recently, and hoping we'll find a good journal for it soon. But that, I think, is kind of the more umbrella of different metabolic interventions, including a ketogenic diet, and how that would mechanistically be helpful for the brain. So excited.
Well, yeah, if anyone asked, or is skeptical about how food affects the brain, just teach them about the ketogenic diet for childhood epilepsy. It can take away seizures overnight. It's like,
50%.
certainly can affect the brain, but
Yeah.
again, Eric Kossoff, who still is in the field at Johns Hopkins, laments that most of the neurologists still use drugs for children with epilepsy. So, while we have all of this, so don't get too hung up on having to fix and change the minds of the drug prescribers. But
Yeah. Well, the last thing I'll say is that I have started an initiative um, because so I really care about, the evidence base, and then I care about access to care. Those are the two things for me that I feel like is my, purpose in my career. Those are the two things. And so access to care is something I'm trying to work on. And so I'm building this virtual remote monitoring solution for giving metabolic psychiatry care to other clinics, other providers. They don't necessarily have to adopt the protocol or train themselves or learn how to do, but we support them and their patients. And that's kind of the way that I'm thinking about providing a solution.
excellent. Yeah, especially, the tool that I teach with food, you don't need a doctor's prescription, right? You don't have to have doing it through the grassroots, teaching people how to use food, really, and having that kind of monitoring and mentoring is a great way to go. Fantastic.
Yeah.
Well,
Thank you for putting all
I'll
that.
let you go. Thank you for chatting. Happy New Year. Hope you have a wonderful start and then progress through the year. Hope to see you soon.
Thank you. Yeah, it's wonderful speaking with you.
Thanks, Shebani.
Take care.
Bye-bye.
Bye.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.